which is breast cancer. So this is a type of malignancy you will encounter anywhere in the oncology facility locally. What is the expectation at the end of the session? At the end of the session, you are expected to outline the possible risk factor for breast cancer, and you should to able to understand the histological classification, staging, sign and symptoms of breast cancer, and finally, you should be able to understand about the treatment modalities for different stages of breast cancer. So those are the main objectives we're going to see together up to the end of the session. So as usual, I'm expecting your active participations are very important. So please try to be very active as much as possible. When you say breast cancer, it is a malignant proliferation of epithelial cells. By that, it is very common either in the duct or in the lobules. So I hope you know about the anatomy of the breast. So normally the lobules are the one that secretes the milk, and the duct is normally the tube that allows the drainage of the milk to the nipple. So this is where most of the time where the cells in the breast begin to grow out of control. That is when we are going to say breast cancer. Then most of the time, most breast cancer began in the duct that carry the milk. So ductal carcinoma of the breast is the most common type of breast cancer based on epidemiological studies. However, like around few percentage, small some status in the gland that makes the milk, that is the lobula. So ductal carcinoma is the most common histology. Lobular carcinoma it accounts like a few percentage of breast cancer in the clinical setting. So when you look at even epidemiologically, it is the second leading cause of death among women population, which is exceeded only by lung cancer. Then the disease occur almost entirely in women, but remember, few men can also get breast cancer. Apart from that, despite I don't really know about why it is common, the most common type of breast cancer is usually unilateral, and it is very common in the left breast. But no one knows, like according to the information I have, and based on like my capacity to search, I didn't see why it is very common in the left breast. But anatomically, the left breast is usually bigger than the right breast. I don't know whether that increases the chance of breast cancer. But anyways, left breast unilateral left breast is usually very common. But remember, if it is not treated, there is a possibility that can involve the right breast. So if it is not treated, it can actually involve the other breast. So it is very common. But in most of our setting, the left breast is involved more frequently than the right breast, according to epidemiological studies. Then I think I alluded when we were discussing about the introductory session. So in terms of new cases, still breast is actually cancer is still the leading, even according to the Global Can report of 2020. So still Global Can reported normally in the year 2020 globally, breast cancer is still the leading type of cancer among all female population. Then, when you look at the epidemiology locally, even according to the Global Can 2020 report in Kenya, still breast cancer is the leading type of cancer in female population. So that is why we are actually giving much emphasis about breast cancer. Then, what are the possible etiologies of breast cancer? Maybe can we actually spend few minutes to discuss to get feedback from you about the possible etiologies? The exact etiology, almost for a majority of the cancer, the exact etiology is not really known. That is why we're actually discussing about is there any possible risk? The higher the number of the risk factor, the higher the chance of having breast cancer. So what are the possible risk factors of breast cancer? Maybe can you outline some of them? Any? A risk factor for breast cancer.
Genetics.
Sorry, can you speak up a bit?
Genetics.
Yeah, there is a possibility of genetics. Huh? As you can see from here, when someone undergo breast cancer A1, breast cancer A2, and P53 mutation, remember those BRCA1, BRCA2, and P53, they are tumor suppressor genes. So if there is a mutation of those type of genes, the probability of the probability of having cancer is very high. Not only even breast cancer, but the probability of having other type of cancer is very high. Okay, good. Genetics. Any other?
Diet.
Sorry, diet. What kind of diet increases risk of cancer? What kind of diet?
Taking a lot of processed food.
Yeah, yes, processed food, and actually diet which is rich in high fat, it can actually even increase risk of cancer. Okay, good. Any other? So what about the possibility of gender? You know why it is common in female? Why it is common in female? Because we all have breasts. The difference is only the size. So why it is common in female? Any idea? Yes,
I think I
Mhm,
think the female it has to go like the growth. It has to undergo the growth.
mhm.
So there's a higher chance of proliferation of the cells.
Yeah, that is good, by the way. Yeah, because of the hormone, there is high probability like it undergo proliferation. And according to even different clinical studies, the estrogen and progesterone level are the one that can increase the chance of proliferation and ultimately to become malignant. So those hormones are very higher in quantity or quantitatively, they are very higher in female than male. That is why the risk is actually very higher in female. Okay, then apart from that, age is actually, by the way, the more we age, the higher the incidence of cancer. For any type of malignancy, as we age, the probability of getting cancer is actually very high because most of the time, like the transformation from early stage, like that is the genetic mutation to undergo malignant transformation, it will take longer time. Unless the patient is actually high risk, it usually takes a longer time. Because of that reason, usually the mean age of diagnosis is usually above 50 years old. So that is why age normally increases. The incidence increases with age. Then, most importantly, by the way, family history of breast cancer is actually very high. So if someone has having first degree relative, like first degree relatives means your nuclear family, like brother, sister, then mother, father. So if you do have high family history of breast cancer in the first degree relative, the chances of breast cancer is actually very high. That is why if someone has family history of breast cancer, usually screening in the early age is very, very important. Even the American Society of Cancer usually recommends if someone has a family history of breast cancer, they have to start the screening using mammogram at the age of 30 years every year. So that is a recommendation. Then, apart from that, the other factor that can increase the chances of breast cancers are usually prolonged exposure to the estrogen hormone. So, any factor that increases the prolonged exposure for estrogen hormone, we call them endocrine factor, can increase the chances of breast cancer. For example, you can actually even see the early menarche, like less than 12 years, the chances of with the moment they start having period, that is when they are actually producing more of the estrogen and progesterone. So the sooner the menstrual period it happens, the longer the duration of estrogen exposure. So this ultimately increases the chance of having breast cancer. Then nulliparity. So nulliparity is related to the level of estrogen. That means if they are not actual, if they are nulliparous, their exposure to estrogen level is usually very high. Then late menopause. Remember, like the late menopause is usually is if it is above 55 years, you can actually even imagine the duration of exposure of estrogen. So like being female is a risk factor because of endocrine factor. Then late age at first full-time birth, that is above 30 years, and long-term use of hormonal replacement therapy. Either hormonal replacement therapy after menopause, that is postmenopausal hormonal replacement therapy, or even the use of hormonal oral contraceptive for long period of time has some chances to increase risk of cancer, breast cancer. So you can actually even imagine the higher the number of factors, the higher the chances. That is why the exact etiology is not really known. And it is very hard to say, like the patient was actually having breast cancer because of this condition. So we just normally look at the possible risk factor and then we estimate the probability. Then the other environmental and lifestyle factor is a diet increase in fat and calorie intake, then obesity. Yeah? You know, obesity increases the circulating level of estrogen. So because of that, obesity in female can increase the chance. Then the other are the smoking, alcohol, reduced physical activity, then radiation exposure below 20 years, 30 years. Those are some of the factors that can increase the chances. So those are the main factor. Then I think this was a study done somewhere about to show about the relative risk of breast cancer. You can actually even imagine when someone is having mutation of this one, the risk is almost like 10 times. If you see, like this is the relative risk. So if you see, if someone has higher like a mutation of BRCA1 and 2 mutation, like the relative risk is like 10 times. Like early menarche, you can actually even see it is just like less than 2 times. Then late age at first childbirth, you can actually even see the risk is like twice. Benign breast disease, the relative risk is like 4 times. Hormone replacement therapy, you can actually even see it is less than 2. Alcohol, you can see alcohol and family history, it is just like equivalent to 2 times. Then hormonal contraceptive, it's almost like 1.5 risk. So those are the relative risk according to various studies. So like if someone is having, that is why if you see the degree of risk, BRCA1 or 2 mutation usually increases the risk of what? The risk of breast cancer. So this is a very important information to note. That is why the American Cancer Society usually recommends if someone has having this mutation, it is recommended to undergo frequent monitoring. Okay, now,
Sir,
yes, please.
I have a question.
Yes, please.
Can breastfeeding be a risk factor to breast cancer?
No. So that one, it does not have that. Yeah, do you know, by the way, the moment they feed, remember about the lactational amenorrhea. So the probability of production of estrogen and the progesterone is usually reduced when they are actually breastfeeding. That is why in the first 6 months, if the first 6 months of lactation, usually the possibility of pregnancy is very likely, especially if she does not have any menstruation, it is very likely to happen in the first 6 months because of lactational amenorrhea. This is also one method of natural method of contraceptive. So breastfeeding normally does not have a risk. Good question.
In relation to that, but what of the cases where you hear like women like who are breastfeeding, they like the ducts are clogged? Will that be as a result of cancer or is just blockage of the duct?
By the way, without actually considering mammogram, remember it can be a benign tumor or just like a blockage due to other factors. It is very unlikely to say, but usually happen during the first. After birth, usually it happens, but after some time, it usually go away, that issue. So without saying, without actually checking, screening the breast, it is very unlikely to say this one is just due to cancer. Remember, even we will see later biopsy, yeah, without actually checking the biopsy, like the pathologist do and check the cell nature to say cancerous or not. Without even that, we cannot say the patient was having breast cancer. Yeah, so I don't think so. Like without confirming that, it is very unlikely. But as you said, those kind of problems usually happen during the first like after a few days of delivery. In the first few days, usually this is a common problem. I don't think so. It has something related to having cancer. I don't know whether it satisfied what I said.
Yes, you have. Thank you.
Yeah, yes, but read more. But that is very important. Without biopsy, we cannot say the patient was having cancer. Okay, any other question? Okay, then. So now, can you go through this case study together? In fact, it is very simple. BW is a 59 years old woman. Now, they found normally 2.22 Siemens. But do you know this one is actually, if you see, like that is why self-breast examination is usually recommended. By the way, after the age of 40, normally, like it's usually recommended for the ladies to undergo like self-breast examination. So you just look at around all your breast side, then look at for any mass. You know, sometimes like those masses, because of the fatty nature of the breast, they might not actually see properly. So let them normally try to like do self-examination of their breast along all margins of their breast, if there is any mass or not. So like for this patient, you can actually even see they noted 2.2 centimeter mass in the upper outer quadrant of her left breast doing routine screening mammogram. By the way, mammogram is just for screening. It normally use a smaller radiation. Okay, then the rest of her physical examination is unremarkable and she has no complaint. All laboratory values are within the normal range and the chest x-ray is negative. Then BW reports that she has her first menstrual cycle at the age of 10 years and had regular periods since that time. She is married but have never pregnant. Remember, pregnancy is protective. Then what are the BW risk factor for developing breast cancer? So I think the question is actually very straightforward. So what are the possible risk factors for this patient?
Age.
Sorry?
Age.
Age, yeah, 59 years. It's older, so mostly the mean age of diagnosis is above 50 years. So she's older, good. Any other?
Nulliparity.
I didn't hear.
She's never given birth. Nulliparity.
Yeah, nulliparity, exactly, yes. That is another factor. Any other?
Early menarche.
Yes, early menarche. So at the age of 10 years, that means like in combination with nulliparity, the duration of exposure for the estrogen is actually very known. So remember, as compared to when you compare estrogen and progesterone, the risk for breast cancer is usually very high with estrogen. You know, estrogen promote proliferation. So because of that, normally it is very, very common. So as you said, those are the possible risk factor for this patient. Okay, good. Now, let me take you through about the histological classification. By the way, when you go to maybe, like especially when you go to like the Kenyatta Referral Hospital, most likely even you might get a chances. I will talk to maybe Dr. Larry because he's usually the one who is going to that place. I'll talk to him, so maybe at least you'll see few cases. Most likely you cannot miss, at least in the surgical ward, you cannot miss. Then also you discover by yourself. Sometimes it is good. Don't expect everything like from the lecture. Sometimes because of aging, like different individuals have different motivation level. So because of that, you try to discover by yourself. And lead, even you can lead even the lecturer when to see this kind of cases. So can you take us? So these kind of strategies can work even when you are not satisfied sometimes. Okay, good. So histologically, it can be invasive or non-invasive. So when you say invasive, it is normally the oncologist or normally they will check histologically to say whether the cancer is actually invasive. So when it grows outside of, when it is involving outside the breast, that is when you are going to say invasive. But non-invasives are usually they're actually primarily located within the breast tissues. But the most common one is actually the invasive ductal carcinoma, is the most common histology from the breast cancer. So, by the way, if some of you are actually even interested, you can actually even think about what kind of researches I can do as part of my project as a partial fulfillment for undergraduate program. So you just think about it, what kind of investigation can I do in breast cancer? Because it is very prevalent, so you have to start thinking, the sooner the better. Then invasive are actually the most common. Even from the invasive, the ductal carcinoma is actually the most common. Yes. So lobular account is like 20%, ductal account is like for 80%. So invasive ductal carcinoma is actually the most common histological classification of breast cancer. So even I think around 3 or 4 students are working on breast cancer. So when we look at even the report, most of them are actually invasive ductal carcinoma of the breast. Okay, then apart from histological classification, there is something which you need to know, especially when you are discussing about breast cancer, the possibility of hormone receptor status. Remember, when you say hormone receptor status, we're actually referring to which hormones are, or which hormone is the most likely offending agent to cause the breast cancer. That is why they normally take biopsy, like from the site of the lesion, then they undergo histochemical test. If you are actually interested, you can read further the immunohistochemistry test to identify the hormone receptor status. And the report is usually either positive or negative in our setting. They don't estimate quantitatively, it is just qualitative test, positive or negative. So a patient can be ER or PR positive, which accounts like the majority of the cases. That is why females are high risk. If they are actually, because the majority of the cases are usually hormone receptor positive, that means it is mainly due to the hormone that causes the risk of having breast cancer. So some can be AR/PR positive, some they are known as HER2 positive. When the HER stands for human epidermal growth factor zeta 2 positive. So by the way, if someone is actually having HER2 positive overexpression from the site of the tumor, this one is actually the possibility of cure is very likely, and the tumor is actually very aggressive and fast growing. So the sooner the intervention, the better the outcome. Otherwise, the possibility of cure is usually very minimal. We shall discuss later. In majority of the breast cancer, the goal of therapy is usually to cure the condition. So because of that, it's usually very unlikely. Then it accounts 20% of the breast cancer cases. One student is actually doing a study to assess how the outcome of HER2 positive breast cancer. In fact, she really did a nice job. When I was doing my own assessment, she really did a nice job. And the cases are very few because she managed to get only like 50 patients, and she was about to finalize the report. And then sometimes they can be triple positive, like ER, PR, and HER2. There is a possibility. for like triple positive, that means the patient was actually expressing for all the receptor, and that means the risk is very high. Then about say triple negative, that means the patient was not expressing, or the tumor was not expressing for estrogen, progesterone, and HER2 hormone. So by the way, triple negative is usually grow and spread faster and most other type of breast cancer. If the mother is actually triple negative and HER2 positive, that is very aggressive. Huh? So this one is very common in younger women. Do you know, by the way, if you detect breast cancer in the younger population, it's usually very aggressive and it's actually very fast growing in nature. So that is how the tumor behaves in the younger population, especially below the age of 40 years. Okay, so this is how the diagnosis, so how the classification of breast cancer based on the hormone receptor status. Okay, fine. So as I said before, the majority of them are usually ER or PR positive. Then another thing to note is the higher the hormone receptor positivity, that means for estrogen, ER plus, or progesterone positive, PR positive, it is usually the response is very good. By the way, if the patient is having positive for ER and PR, the response is usually very good, like with hormonal therapies. But HR positive tumors are usually very common in postmenopausal patients than in premenopausal women. So you have to know this one, because most of the premenopausal women is usually having what? They are usually having triple negative of ER, PR, and negative type of breast cancer. Okay, then apart from that, what is very important with HR positivity is usually it usually grows more slowly than HR negative tumor. So that is why this hormone receptor status assessment is really very key, so that you can actually even say about the possible prognosis of the disease. Like if they are HR positive, now you can actually even say, oh, this tumor is actually very slow growing. Yes, then the response is actually very good. So the possibility of prognosis is usually expected to be very good. So that is very important. So you can actually even see the chance of survival built on this hormone receptor status of the patient. Then now let me take you through about the clinical presentation. So how does a patient having breast cancer presents with? So most of the common early presentation is usually painless lump. By the majority of the patients, those are the most common findings. Painless lump, but mostly unilateral. But sometimes you can actually see stabbing or aching pain, but it is very in few cases. So majority of the patients, they normally have a painless lump at during the usual screening. Then uncommon, but it can happen, is sometimes nipple discharge or eczema appearance of the nipple, and prominent skin edema, redness, worms, and induration, which is very common in the inflammatory type of breast cancer, but those are not very common. That is why when you actually advise our patients, you need to ask them whether, like during examination, we need to ask them whether there is any lump anywhere around the breast. So if they notice that one, now they are supposed to undergo mammogram. So a mammogram is actually one of the most common early screening methods in breast cancer. Okay, now when it becomes in advanced stage, but most of our patients normally they came for treatment when they are already in advanced stage. That means it already undergo metastasis to distant organ. So depending on the organs involved, you'll actually explain or expect different clinical presentation. If bone involved, they complain bone pain. If the lung is involved, they complain difficulty of breathing. If there is involvement of the liver, abdominal enlargement, jaundice. If brain, you are going to see a changes, like they're complaining headache, confusion, then disorientation in person, place, and time is very, very common. So those are the most common. So in cases of breast cancer, those are the most common types of metastasis: lymph, skin, bone, liver, lung, and brain. By the way, it can actually usually it involves the nearby lymph nodes, including the lymph node around the axillary areas. Then sometimes it can involve even the contralateral breast, that is the right breast most commonly can be involved. So those are the clinical presentation that can happen at the advanced stage. Now, let us see about staging of breast cancer. So staging is usually based on TNM staging. In the introductory session, I mentioned about what does TNM staging stands for. So T is the size of the tumor, N lymph node involvement, and whether there is a metastasis or not. So when you say stage 1, when you say stage 1, it is usually represents a small primary tumor without lymph node involvement. So in stage 1, it is only within the breast. But stage 2, the majority of the disease involves regional lymph nodes. So generally, stage 1 and stage 2 breast cancers are known as early stage of breast cancer, and the possibility of cure is very, very high. So when you say cure, it does not mean that like the patient was completely, the tumor was completely disappeared, but it might be actually longer or complete remission. Maybe we don't know how long it will undergo complete remission. So anyways, the possibility of cure is very high, especially with stage 1 and stage 2 disease, even including stage 3. So stage 3, we call them locally advanced disease. So they are still within the breast, but there is extensive involvement of the lymph node, and the size of the tumor is usually bigger in stage 3 type of tumor. Okay, so when you say stage 4, regardless of the size of the tumor and lymph node involvement, stage 4 means what it is actually metastasis to distant organ. So this one is advanced or metastatic stage, and the goal of treatment here is just only palliative. So the possibility of cure is very unlikely. Our goal is just to increase quality of life of the patient. So this is the staging. I think when you get time, you can actually read more. Like when you say stage 0 means it is carcinoma in situ. It is just the tumor is just localized. Then stage 1 is the size of the tumor is T1. So you can actually even see what does T1 means. It is when the tumor size is less than 2 centimeters. So this one, they have to do extensive imaging, CT scan, even to stage the breast cancer. But there is no lymph node involvement. So stage 2, there is the size of the tumor can be between 0 to T3. That means T3, you can see the size of the tumor is above 5 centimeter NDTC. So anyway, this is how they are going to stage. This is not as such important for you, but if you are interested, you can actually do. But most of the time, it is the role of the oncologist who is supposed to stage. Yeah? Then when you say M0 means no metastasis, M1 means there is metastasis. So regardless of the size of the tumor and lymph node involvement, if there is distant metastasis, we still say the patient was advanced stage of breast cancer. So you can actually even see what does N1 stands for. Yes, there is ipsilateral lymph node involvement. Then N2, ipsilateral but axillary lymph node involvement. And it is N3, there is actually infraclavicular involvement. So this is how they are going to stages. But anyway, What is very important for the pharmacy context is you know what is the stage of the disease. Then after that, remember when you say stage 1, there is no lymph involvement. That means the tumor is within. Then stage 2, but the size of the tumor is bigger, but there is extensive lymph node involvement. Stage 3 is actually more extensive. There is the size is bigger and more extensive, but still there is no metastasis. Can you see even the size of the tumor in stage 3? It is usually, especially B stage, is any size, but there is actual involvement of the skin. That means it go beyond the breast tissue. So this is how they are grading the tumor. Okay, having said this, now before we go to the treatment modalities, now let me take you through about screening modalities. What is the recommendation from American Cancer Society? So the first thing you need to know is, like, if a person or if a woman does not have a personal history of breast cancer, strong family history of breast cancer, or any genetic problem or any genetic mutation, to increase, like, all women are average risk. That means if you don't have all those parameters, you are what? Average risk. So for average risk individual, there are actually different recommendations. If they are between 42, 44, it's just up to them to decide. If they want, they can do annual breast examination using mammogram, as you can see from this diagram. Can you see normally like how they are examining the breast? So they put the breast on the tool, like as you can see, they normally they screen, they look at it, whether it undergo any lesion in the breast tissue or not. But if they are between 45 to 54, they are supposed to get mammogram every year. So from this summary, if a woman is above 40 years, it is advisable to do what? Mammogram screening at least every year. So because why? The sooner the better. Remember, even in the early stage of the disease, that is stage 1, even surgical resection of the tumor at the site of the lesion can be even curative. So because of that, it is the sooner the better. So that is why, like some medical facilities like KNH, they usually even advert normally pre-screening for breast cancer, so that they increase awareness week for breast cancer, cervical cancer, because they are very common in female population. Okay, good. Now, let us break for 1 minute to see this case study. So maybe can you go through for 1 minute, then I will get back to you. So what is your opinion? According to, sorry, average risk. So why? Why average risk?
She has no personal history of breast cancer, neither does she have a strong family history, because it's only a distant relative who has had breast cancer. No first, no mother, father, or first grandmother, those things.
Yes, good. So like the person is, the woman is like average risk because of the reason you mentioned. So like according to even the American Cancer Society recommendation, they can actually decide to do annual screening or not, or they just wait. So But the best recommendation, I think there is also another society that recommends after 40 years. So it's better, by the way. Even me, I normally support, like if they are above 40, they better do screening every year. Okay. Then when you say high risk, like a patient is having known breast cancer gene mutation or have a strong family history of breast cancer. So like this one, we call them high risk. So because of that, like for the best recommendation, even according to the American Cancer Society, annual mammography and breast MRI should be initiated starting at the age of 30 years because they are actually high risk. But usually for younger population of high risk, usually MRI is better. Do you know? sorry. What kind of radiation normally MRI uses? What kind of radiation MRI normally uses? I think it uses radio frequency and magnetic field. So I can say for MRI, there is no risk because they don't use radiation. So, but this one, it has actually some radiation. So, and in younger population, remember in younger population, the breasts are usually very dense. So mammogram will not actually give a best resolution of the imaging. Because of that, for younger population around the age of 30, it is usually advisable to do MRI if they can actually afford. Then apart from that, if we start normally radiating with an annual mammogram, even the mammogram radiation can increase some risk of breast cancer. So because of that, MRI is usually advisable for high-risk individuals. For high-risk individuals, it's usually recommended to use MRI. So, but because of various conditions, cancer treatment is relatively what do I say? Yeah, it's not really like the patient was not really getting the perfect treatment. We shall talk even later how expensive the drug is because I just counter checked like the current treatment modalities in the oncology setting of KNH. Then I will share normally what they told me after a while. Then when you look at in terms of diagnosis, remember the patient do physical examination, self-examination. Then after that, they do histology. Sorry, they do mammogram. Then mostly they do palpation, radiology, needle aspiration for cytology. But mostly biopsy is usually the most uh, the gold standard, the diagnosis. But triple assessment is usually very common. Yeah, for any symptomatic breast mass, a patient, they do radiology, high needle aspiration, and for confirmation, biopsy is usually mandatory. Yes. Okay, so those are, but radiology, by the way, they can use mammogram, ultrasound of the breast, or MRI. Yes, ultrasound and MRI, they do have low risk of radiation because they are not using radiation. Okay, now let us discuss about prevention modalities. So for the diagnosis, remember, biopsy is the gold standard. The others are also part of the diagnosis approach. So is it possible to prevent breast cancer? Now let us see this case study together for 1 minute. So read for 1 minute, then I will get back to you shortly. So what is your opinion? Huh? She's a nurse and she want to deliver a talk about breast cancer awareness. Huh? Maybe for the community level, huh? Or some kind of community activity. Huh? So what common modalities of cancer prevention that MP should address, and what chemo preventive agents should she include? So what is your opinion? Any opinion?
I think
Mhm.
she should talk about the environmental and the lifestyle factors, because those ones you can prevent,
Yes.
and also any drugs that are taken by women to increase exposure to estrogen. Yes.
Good. Maybe they can reduce at least like estrogen-based contraceptive. They can use the progesterone alone. Yeah, that is good. Also recommendation. Do we have any chemo preventive agents that can reduce the risk of breast cancer in high-risk individuals?
Tamoxifen.
Yeah, tamoxifen is the one that can be used. So those are tamoxifen, raloxifene. She's supposed to take about those chemo prevention strategies, apart from what you said. Then, do you know about the surgical component of the surgical components of and the prophylaxis in high-risk individual? They can do prophylactic mastectomy. If the woman is high risk, instead of actually developing the cancer later her life, then for high-risk individual, if the woman agree, they can do prophylactic mastectomy with reconstruction. Then otherwise, the two agents that is approved for prevention are tamoxifen 20 milligram daily for 5 years and aloxifene 60 milligram daily for 5 years. But the problem is those class of drugs, they are actually with prolonged use, they can increase the risk of deep vein thrombosis. Okay, so those are the strategies. So in short, patient education about the risk factor. For high risk, consider mastectomy and chemo prevention. Those are the strategies that can be considered in the prevention of breast cancer. Now we're heading to management. So I'm expecting if you actually actively follow, at this point, you actually have some idea about what breast cancer, what are the clinical presentation, how do we diagnose, what are the risk factors. Now by heading, how do we treat this condition? So according to the current guideline, those are the modalities we are going to use in managing breast cancer. There is a component of surgery, chemotherapy, radiotherapy, and hormonal therapy. But remember, hormonal therapy is only considered if the patient is hormone receptor positive. So, by the way, without assessing the hormone status of the patient, you are not supposed to consider even hormonal therapies. The biological agents are normally trastuzumab, what I said when I was discussing about the introductory session. So this one is the most commonly approved drug in HR2 positive breast cancer. Okay, now let's see about how do we treat early stage. So early stage, I said, is stage 1 and 2. So this one, only like stage 2 is only involving the lymph node, but stage 1 is only within the breast. So what is the goal? The goal is curative. So if the goal is curative, how do we manage? According to different guidelines, in stage 1 and stage 2, surgery alone can be curative. But in stage 2 disease, because there is lymph node involvement, it is usually advisable to consider systemic adjuvant therapy. Yes. So that is very, very important information to know. So what are the surgical modalities? So the surgical modalities can be radical mastectomy. That means the whole breast will be resected surgically, or breast conservation therapy. So according to the ESMO guideline, remember what I mentioned during the introduction, the European Society of Medical Oncology guideline and the NCCN guidelines. Those are the most commonly used guideline in the management of cancer. So according to those guidelines, for stage 1 disease or stage 1 and stage 2 disease, it is advisable to give lumpectomy. Yeah? Lumpectomy means they just resect only the side of the tumor. Then you radiate for 4 to 6 weeks. Radiation therapy is comparatively having the same treatment outcome of giving radical mastectomy. So because of cosmetic value, this one is the most common treatment modalities. But normally they give for the patient to choose, yeah, which one normally to pick. But according to that guideline, even because of cosmetic benefit, this one is actually more preferred treatment modalities for early stage of the disease. So while you are resecting the whole breast, if the outcomes are actually the same as that of radical mastectomy. Okay, so for stage 2 disease, it's usually systemic adjuvant therapy is usually recommended. Okay, so this is how we're managing stage 1 and stage 2 disease. So this is how radical mastectomy look like. Like the whole breast will be normally. So because of the psychological impact and the possibility of having some other psychiatric disorder, it is better. This one is not really usually recommended unless like the disease is usually advanced. So like the management of cancer is usually holistic. There's a radiologist, like they call it this interventional or radio oncologist. They don't have a name anyways. There is involvement of the surgeon, and there's also the medical oncologist. So like all those three normally agree together which treatment modality will be the best for each individual patient. So this is how a lumpectomy look like. So this is the breast conservation therapy. You can actually even see this is a tumor, then they resect the tumor, then they radiate the tumor. So this is actually the most commonly recommended treatment modality in the early stage of the disease. Now that is about stage 1 and stage 2. Then what if the patient was having stage 3? So according to the guideline, if the patient was having stage 3, this one is locally advanced because there is involvement of the lymph node, but it's more extensive and the size of the tumor is bigger. Then in this stage, in the stage of the disease, the guideline recommends surgery, radiation therapy, chemotherapy is usually administered in an aggressive approach. So combination treatment of surgery, radiation therapy, chemotherapy is usually administered. So what is the goal? Even for stage 3 disease, the goal is usually curative. But in order to, because of that goal, most of the time, chemotherapy is usually administered. Remember, the size of the tumor is usually very big at the moment, so neoadjuvant chemotherapy is usually administered before surgery. So you normally consider what? Give chemo first so that you shrink the tumor at least 50%. Then after that, we are going to conduct the surgery. Then after that, if the patient is actually, then after that, radiation therapy. Then if the patient is hormone receptor positive, that is when we are going to consider what? The hormonal therapy. So chemotherapy regimens are usually similar, what we have used in adjuvant setting. By the way, I will talk later. Most of the treatment modalities we are using in the neoadjuvant setting or adjuvant setting, in case of chemotherapy, they are usually tested their efficacy in metastatic setting. Because of that, there is no difference in terms of the chemo regimen. Whether we use in neoadjuvant or adjuvant setting, we just still use the same chemo treatment regimen. So according to the current available data, anthracycline-based regimens are usually very effective in breast cancer. So we shall discuss later. Then sometimes we can use neoadjuvant endocrine therapy. So when do we use neoadjuvant endocrine therapy is when the patient is hormone receptor positive, but they are not able to receive chemotherapy. You know, remember, there is a chemotherapy component and there is endocrine therapy component. So in terms of achieving rapid response, chemo is better. Endocrine, they are slowly acting. It will take even longer time. But in terms of risk, chemo is usually risky as compared to endocrine therapy. So in case if the patient is having multiple comorbidity status, that is when you are going to consider neoadjuvant endocrine therapy in locally advanced disease. Otherwise, we don't give neoadjuvant endocrine therapy because of lower efficacy. Then, adjuvant radiation therapy is usually recommended for all locally advanced breast cancer patients to minimize local recurrence. So now note, we do have stage 3 breast cancer. So the size of the tumor is very big, so you normally give chemotherapy so that you can shrink. Then after that, you normally do surgery. Then after surgery, that is when you are going to consider radiation therapy. Then after you give radiation therapy, if the patient is hormone receptor positive, that is when you are going to consider what? The endocrine therapies. Okay, then how do we treat advanced stage of the disease? Stage 4. Now the goal is just to improve quality of life. So in advanced stage of the disease, by the way, most of the time, if they are hormone receptor positive, we normally give hormonal therapy. So despite even we consider surgery, here the goal is just only to improve the symptoms. So, but most of the guideline recommend is if they are hormone receptor positive, then usually you give hormonal therapy. But in case if the tumor is normally hormone refractory or if they are HR negative, you can actually consider systemic chemotherapy. But with monitoring, because the disease is advanced, even the patient cannot tolerate the chemo. Otherwise, there is a possibility to consider palliative surgery and even palliative radiation therapy. Yeah? So if there is a brain involvement, spinal cord compression, there is a possibility to do surgery. And if there is involvement of the bone, maybe you can radiate, sometimes even whole brain radiation in case of brain metastasis, or even radiation in case of spinal cord compression, so that you distract or you kill the tumor. So still the treatment is actually palliative. So still the treatment is palliative. Now I'm taking you through about the chemo regimen. So what are we going to use? What are the regimens we are going to use in adjuvant setting? So in adjuvant setting, remember, we consider chemo only when the patient is having like stage 2 disease. The recommendation is within 3 weeks of treatment or surgical removal. Now that is when you are going to consider the chemo regimen. As I said before, in terms of response, the anthracycline-based regimens are usually preferred. So what are the most common chemo regimens we are going to use in adjuvant therapy? Adjamycin and cyclophosphamide. So can you see doxorubicin 60 milligram per meter square IV, then cyclophosphamide 600 milligram IV. So both of them are given day 1, then we repeat every 21 days for cycle. So they resect, then they give this regimen. Then apart from that, some doctors normally they prefer AC followed by paclitaxel. That means you give 4 cycles of anthracycline and cyclophosphamide regimen. Then after you complete that 4 cycle, that is when you are going to continue with paclitaxel 175 every 21 days for cycle. So this is, we call it AC followed by taxane. So in most of the setting, unless there is a contraindication, AC or AC followed by paclitaxel are the most common regimen. Then we do have by the variety of regimen. You can actually go through when you get time, but those are the most common. Then there is a dose-dense regimen. So if you remember what we have said, dose-dense means we are reducing the duration of treatment. So we are still using the same AC, but we are repeating every 14 days instead of 21 days. So in this case, the growth factor support, that is GCSF, is usually mandatory to prevent the risk of febrile neutropenia, then followed by paclitaxel every 14 days. So there's also dose-dense AC followed by paclitaxel, but the frequency of dosing is every 14 days. So this is still also can be considered. Then the other ones are CMA, then FAC. There is also TAC. Those are very common regimen. So anyways, when you get here, you can actually familiarize. But remember, you are not supposed to cram, but you have to know the principles of the management. So AC followed by paclitaxel and etc. For how many cycles we are going to give, then you monitor. By the way, remember, if the patient is not responding, maybe within 2-3 cycles, now they can actually even change the regimen. So, but this is a general recommendation we are going to give for breast cancer. Now, can I take you together about the dose-limiting toxicity of some of the drugs used in management of breast cancer? Doxorubicin, what do you expect when you take doxorubicin?
Cardiomyopathy.
Yes, cardiomyopathy. So echocardiogram and assessing the cumulative dose is usually mandatory, yes? Okay, good. Liposomal doxorubicin is usually hand-foot syndrome is very common. We have mentioned about when we are discussing that. Then myelosuppression. When you say taxane, expect about hypersensitivity and neutropenia, myelosuppression. Docetaxel, mostly fluid retention. Then anti-metabolite capecitabine, diarrhea and hand-foot syndrome is very common, and then cyclophosphamide expect hemorrhagic cystitis. So you can actually even, when you get time, read what about the at least very special, unique dose-limiting toxicities of some of the class of drugs. Okay, now endocrine therapies, adjuvant endocrine therapies. So remember, those adjuvant endocrine therapies are mainly important in hormone receptor positive breast cancer. So the goal is we need to reduce the level of estrogen that is most likely a risk factor for that cancer. Yeah, that is the one we are going to use. So, so we do have different endocrine therapies, but I will talk what are the most common endocrine therapies in our setting. So remember, combination therapies has not demonstrated any efficacy benefit for endocrine therapy, so we don't combine together. But then if tamoxifen is not effective, we can switch to another endocrine therapy, but we don't combine because according to randomized control trial studies, combination does not have any benefit, rather increase toxicities. So what are the most common endocrine therapies? Anti-estrogen, tamoxifen is like the gold standard, but we do have also surgical component, ovarian radiation. That means so that you reduce the ovary, so ovary will not produce estrogen. Luteinizing hormone, releasing hormone agonists, we do have, and also have aromatis enzyme inhibitor. So anastrozole, letrozole, and exemestane, all of them are available locally. So when you think about adjuvant endocrine therapy in breast cancer, don't forget about tamoxifen and aromatis enzyme inhibitor. The others, they are not commonly used. I just normally mention for the sake of information. So they can use. So is there any difference in the efficacy? No, but there is a difference whether to use in the premenopausal woman or postmenopausal woman. So we shall discuss it shortly. So let us see about tamoxifen. Tamoxifen is a gold standard adjuvant hormonal therapy. So it is selective estrogen receptor modulator. Tamoxifen can be used both in premenopausal and postmenopausal women for hormone receptor positive breast cancer. It can be used, but mainly it is more effective in the premenopausal woman. It's more effective in the premenopausal woman. But if the mother is postmenopausal, that is when we are going to consider Aromatis enzyme inhibitor. By the way, there was a study, a comparative study between Aromatis enzyme inhibitor and tamoxifen in the postmenopausal woman. According to that study, there was no difference in survival outcome. But in terms of duration of time to progression of the disease, this one is a bit longer than tamoxifen when you use in the postmenopausal woman. But the problem is when you give tamoxifen in the postmenopausal woman, it has a lot of side effects, including risk of DVT. I think the day before yesterday, one doctor told me normally she encountered DVT due to the use of tamoxifen. So because of that, in the premenopausal woman, the first line is tamoxifen. In the postmenopausal woman, the first line is usually aromatic enzyme inhibitor. Now the question is, how do they know whether the mother is premenopausal or postmenopausal? Maybe can I get feedback? We have said tamoxifen is in the premenopausal mostly, first line, but if not already, we are going to use, in fact, in the premenopausal, I don't know what to use. If if that one is, if tamoxifen is not working, is very hard. What medication to use? So how do we know whether the mother is premenopausal or postmenopausal? How do you know?
So you said a postmenopausal woman, there is a reduction in the levels of estrogen circulating.
Okay. Huh?
Yeah.
That means so we are we going to check are we going to do a lab test to assess the estrogen level in the serum?
Pardon?
So what are you going to do when to say like the mother is postmenopausal, so we are going to use aromatic enzyme inhibitor? How do we assess whether they are pre or postmenopausal? I think last year in the fall semester, I don't know whether we mentioned about menopause. If the mother is not able to see menstruation for consecutive of 1 year, that is when we say the mother is actually undergoing menopause. But nowadays, there are several factors. You don't know whether the mother is really premenopausal or not. So that is not really like the confirmative test you are going to assess. So what are you going to do? Are we going to ask the mother whether she was having a period or not for the past 12 years? Or which one is a simpler approach to assess? It's just a screening for the hormone level and say the mother is premenopausal or postmenopausal. Or we look at the age of the patient and see if it is above 49, we expect the mother is undergoing menopause. If it's below, we say the mother is premenopausal.
I think to ask is simple.
So to ask is very simple, huh?
Yeah.
Okay, yeah, we can ask. But when you look at in terms of treatment, it's not really very, it's not really very easy, yeah? Because if they initiate Aromatis enzyme inhibitor, but they are perimenopausal, it is no longer effective. The patient is getting the treatment, but they're not controlling the tumor. So because of that, the correct practice as far from the oncologist I spoke, they usually measure the what you call follicle stimulating hormone, FSH, and the estradiol level. So remember, in menopause, like the ovary is no longer producing what? Estrogen and progesterone. So the moment, so if the ovary is not undergo like menopause, the estrogen level is usually very lower. Then, apart from that, as a result of low estrogen level, the FSH level is usually what? Very high. So the moment estrogen is lower, it sends a signal that actually activates the follicle stimulating hormone from the anterior pituitary to produce more estrogen. But the ovary is no longer responding because the ovary is already aged. So the finding is FSH is usually high, estrogen is actually low. If you get this result from a woman, you can say it is normally what? Postmenopausal woman. But if estrogen is normal and follicle stimulating hormone is normal, we can say the mother is premenopausal. So those are the most common tests normally they are employing currently to assess premenopausal and postmenopausal women. Then, why aromatic enzyme inhibitors are not effective in the premenopausal woman? Why it is not effective? I think I have mentioned before. Why it is not effective in the premenopausal woman?
Because they produce most of their estrogen from the ovary, so giving an aromatase inhibitor would make the situation worse because it will only affect the estrogen that is normally produced from conversion of the adrenal gland androgen secretion. It will just increase estrogen levels.
Exactly. The moment you inhibit the aromatase enzyme, the ovary produce more aromatase, so that to increase the estrogen level. So because of that counter effect, aromatase enzyme inhibitors are no longer effective in the premenopausal woman. This is why you have to assess. We have to assess the patient before we initiate treatment. Okay, good. Then how long do we give aromatase enzyme inhibitor? Yeah, there's a lot of diversity. In fact, I had even a long discussion with the medics about these issues. So, okay, some literature says 10 years. Some literature says like 5 years is adequate, especially for aromatase inhibitor. Like there is no data to support the benefit of extended treatment beyond this duration. So if I was asked like how long the patient was supposed to be on aromatase enzyme inhibitor, you have to give like I will actually say for 5 years. But there are some studies normally showed 10 years is usually recommended. But for tamoxifen, initially it was 5 years, by the way, yeah. But nowadays, according to the latest information, nowadays, like if you give, like they did a comparative studies. So if you give normally for 10 years, normally have a longer survival time as compared to the 5 years treatment. So nowadays, even the guideline recommends you just consider to give for a minimum of 10 years. But beyond that, the study shows like there is no like benefit or there is no evidence to support the benefit to give beyond 10 years. So tamoxifen for 10 years, for the time being, use it for tamoxifen should be given for 10 years, but aromatase enzyme inhibitor has to be given for 5 years. But keep on updating in the future because of the dynamics of the studies. So this is what I was talking about. So according to recent studies, if you give for 10 years, it reduces recurrence rate, reduces even risk of cancer to the opposite breast, and it improves survival. That is why nowadays it is usually given for 10 years. Which one? The tamoxifen one. Okay, now there's another thing which was taken from the American Society of Clinical Oncology. Why I'm just referring like the guideline from the other countries, like especially from the US, because like the guideline, if you see, I don't know, you can actually even see the information is really very inadequate, especially in terms of cancer treatment. So because of that, even the oncology usually refer most of the guidelines from the US. So according to American Society of Clinical Oncology, if the woman is postmenopausal after 5 years, you can actually continue tamoxifen for 10 years, or you can switch to up to 5 years for an aromatis enzyme inhibitor. So let's say the mother is actually at the age of 49, and like the mother undergo menopause at the age of like 5 years, like at the age of 54. So if the mother is undergoing menopause after 5 years, you continue at the time of the treatment, she is premenopausal. You start with tamoxifen, but the moment the patient becomes premenopausal, postmenopausal, that is when you are going to consider aromatic enzyme inhibitors. Or if postmenopausal at the start of hormonal therapy, normally you can offer tamoxifen or aromatic enzyme inhibitor. But the guideline recommends if there is no contraindication, aromatic enzyme inhibitors are usually the first line in postmenopausal women. So anyways, what guides you is actually like the menopausal status of the patient. So it is very important to actually pick. The most important thing is identify at what year the mother is undergoing menopause. So to avoid that confusion, tamoxifen will be actually the best because it can work in both. And the difference is very slight. The difference is actually very slight. Then those are the endocrine therapies we're having currently in managing breast cancer. So the non-steroidal ones, anastrozole 1 milligram, letrozole 2.5, and exemestane is steroidal, which is what 25 milligram. I think I mentioned something about between non-steroidal and steroidal aromatic enzyme inhibitor. There is no difference in outcome, despite the steroidal ones are irreversible inhibitors of aromatic enzyme inhibitor. So there is no difference in the outcome. So we can use any. Yeah, if anastrozole is not effective, we can try with exemestane. By the way, there is one study I read. The possibility of cross resistance is almost minimal among themselves. So if anastrozole is not working, you can use letrozole or exemestane. Yeah, that is very important information to know. Then tamoxifen is usually given 20 milligram oral daily dose. So you can actually even know the doses as well. Anastrozole is 1, letrozole is 2.5. Huh? Okay, then what is the risk of tamoxifen? Risk of thromboembolism, endometrial cancer is usually very high with long-term use. That is why if a patient is actually taking those medications, you have to monitor the possibility of DVT. It can happen at any time. But of course, if the patient is actually taking tamoxifen, you need to tell them do regular exercise, don't actually have a prolonged rest so that they reduce risk of blood clotting. Then what is the most common side effect of aromatic enzyme inhibitor? Osteoporosis. What is the most common side effect of aromatic enzyme inhibitor? Osteoporosis. Okay, why it causes osteoporosis?
Because it further reduces estrogen levels.
Yes, thank you, Tiffany. Because it further reduces estrogen level, and you know about the importance of estrogen in the bone formation. So yeah, that is the major limitation. Then this is the chemo regimen, by the way. Yeah? We can actually even use in metastatic setting or even in the even in the adjuvant setting, this is a chemo regimen. Yeah, but in metastatic setting, normally we continue the cycle until an acceptable toxicity is actually happened or until the disease progression is actually reduced significantly. So we don't know how long, how many cycles we are going to give in case of metastatic breast cancer because the goal is just only palliative. So remember in advanced cases, we can even use monotherapy, paclitaxel. We can use even docetaxel, even liposomal doxorubicin if the patient cannot tolerate combined chemotherapy. So you have to note this one. Then this one is the treatment algorithm of stage 4 or metastatic breast cancer. By the way, it is very simple and straightforward. You can actually read on your own time, which was taken from the Kenya National Guideline in Cancer Management. So it is actually very straightforward. But remember, in metastatic setting, if there is a bone involvement, we're supposed to give bisphosphonate and zoledronic acid. Yeah, the rest is normally, we have already talked about the other. If there is a bone involvement, give the biphosphonate because it reduces what? Further osteoporosis or breakdown of the bone. Okay, then the next point we are going to discuss is about what kind of adjuvant therapies we are going to use when a patient is HER2 positive. So if the patient is actually HER2 overexpressed, as I mentioned before, these tumors are very aggressive, and the response is very minimal. But with trastuzumab treatment, we call it, the brand name is known as Herceptin. You can actually check further. Herceptin is the generic name for trastuzumab. So this is the only available drug in our market for the treatment of HER2 overexpression. So if a patient is actually HER2 positive, HER2 positive, make sure they have to get what? Trastuzumab in the treatment. But the problem is, do you know how much it costs one cycle of trastuzumab? 100,000. That is like the cost of the medication alone. So because of that, most of our patients, they don't get the full cycle. So they are going to give like for 18 courses, 17, some guideline says, I think currently it is 18 courses. So you can actually multiply. So how many patients can afford even? This one is just only for trastuzumab alone. So you can actually even imagine how expensive breast cancer treatment is. Okay, but anyways, then it should not be given concurrently with anthracycline because of cardiotoxicity. But then if the patient is actually taking AC, you have to complete AC first before you consider trastuzumab because of what? Overlapping cardiotoxicities. But of course, the cardiotoxicity is not very severe like that of adramycin. But in ways, you have to monitor every 3 months. Then side effect wise, infusion-related reaction is also very common. Possibility of hypotension and heart failure is actually very common. So how do we give trastuzumab? This is the treatment schedule. So initially we give loading dose, like in cycle 1, we give 88 milligram in cycle 1, but the other cycle, you normally give 6 milligram per kg. So you cycle 1 loading dose of 8 milligram, then you normally repeat every 21 days for 17 courses or 17 cycles. So, but Tiffany, question?
Yes, why does it require 17 cycles when other drugs require maybe 4 or 2 cycles?
Yeah, this one is just based on clinical trial. So the moment you give 17 courses, you are going to achieve the desired response with heart rate overexpression. So this one is just based on the clinical trial. So have you seen even the COVID vaccine? You have to take 2 doses to be fully immune. If you give 1 dose, you don't have full immunity. Yeah, if you see like hepatitis C vaccine B, you have to take 3 doses to be say you are actually fully immune. So for this one to fully effectively suppress and reduce risk of recurrence, this is the maximum duration of treatment you are going to give. But very unlikely, like they told me normally the maximum the patient can get is 8 cycles. That means like that is 800,000. Yeah, beyond that, most of the patient cannot afford. Okay, then, as I've said before, if the ejection fraction is less than 40%, yeah, that one you have to be very, very cautious. Then another point to note is the use of biphosphonate adjuvant therapies. As I said before, this one is very common when there is a bone involvement. So to reduce the further fraction, mostly IV, is usually IV every month. Palmidrone is 90 milligram or hyaluronic acid, which is widely available, given IV once each month. So in combination with calcium and vitamin D is usually recommended. While calcium and vitamin D, it actually reduces the risk of hypocalcemia. But this is very common treatment. Then the other thing is there is also a cancer in male. But everything is identical, by the way. I'm not going to discuss everything is identical. The difference is the majority of the male breast cancers are usually hormone receptor positive and they are highly responsive for tamoxifen endocrine therapies. By the way, according to even the ISMO guideline, so if you have a male breast cancer with hormone receptor positive, give tamoxifen as the first line medication. Everything other thing is actually the same, but the cases are very, very few. Treatment-wise, every other parameters are the same. Then, what are the prognostic factors of breast cancer? Look at the age. If they are younger, the prognosis is very poor. Tumor size. If the tumor size is very big, prognosis is very poor. Then, if there is involvement of lymph node, the prognosis is very poor. If the patient is having ER/PR negative, the prognosis is actually very poor. If they do have HR2 overexpression, the prognosis is actually very poor. So those are the poor prognostic factors of breast cancer. No question.
Yes, what if the patient has started the chemotherapy and they thought they could actually like afford the treatment, then like maybe they couldn't finish the cycles due to like the money issue, the financial aspects. Does it reduce the effectiveness of the therapy, or like what happens?
Yeah, for sure. If they don't complete the cycle because of financial constraint, like we're not very sure, and the possibility of outcome is not as expected. Yeah, that is why they have a minimum of 4 cycle of AC. If they don't have any contraindication or any side effect, a minimum of 4 cycle of AC is supposed to be given. If they miss, yeah, there is a possibility. But this one is just we have no, like we cannot explain. Because like if you are supposed to take 7 days of antibiotics, and if you actually take 3 days, then it can relapse. Yeah, so for effective tumor suppression, the patient is supposed to take the complete cycle. Yeah, unless there is any contraindication or any side effects or any bone marrow suppression. Good. Now, how do you monitor? Mostly they look at the size of the tumor, they do even physical examination, then also tumor marker. I think currently they are doing Ki-67. So this one is actually the most common tumor marker in breast cancer. Then do you know by the way, those HR positive, AR positive, initially it was positive, but after treatment it can be negative. Yes. Otherwise, they look at it, the clinical parameters, clinical improvement, especially in metastatic setting. They look at the mental status. They look at laboratory function test if there is involvement of, and also they are tumor marker in breast cancer. But they told me they don't do this one commonly. They do only the hormone receptor status, as well as the hormone receptor status, as well as the Ki-67. So those are the most common tumor marker that can be considered to assess the treatment. response. So I think that is all about breast cancer. I don't know, like when I look at my time, it is 12:37. So I just left only a few slides, but just like for point of discussion. So do you want to read by yourself, or are we complete? It's just up to you to decide. Can you read by yourself this component and you ready for the next class, or we look at the case studies together? What is your